Good morning. For those of you I haven't met, my name is Wendy Introne, and it's a great pleasure for me to be here this morning. I was asked to talk about the use of nitisinone in Alkaptonuria, and I was very excited about that because I think it's a very timely talk as we're looking forward to therapeutic trials, which are on the sort of immediate horizon. For those of you who have been to conferences with me before, you know that we've conducted a long-term trial, a 3-year trial using nitisinone in patients with Alkaptonuria, and I've presented that data a couple of times. So you might be relieved to know that I'm not going to present that data again. But what I thought I would do is talk a little bit about our experience with nitisinone, sort of the evolution that we took as we moved to the long-term trial, how we came up with the dosing that we used for the trial, our positive experience with the medication, some of the adverse events that occurred during our trials, and then finally, I just want to highlight some information that's been coming out in the children with hereditary tyrosinemia type 1 who've been treated with nitisinone for several decades now, as I think it might influence some of our discussions and our decisions about dosing that we'll use for future trials. So I just want to start off, we started studying Alkaptonuria in 2000, and the initial hope was to learn as much as we could about the disease so that we would be well prepared when treatment trials came down the pike for us. And one of the things that we were thinking about initially was some of the treatment recommendations that had been recommended in the past, which included vitamin C and low protein diets. And we looked, this was all in adults that we studied initially on the protocol. And our data actually is very much in contrast to Dr. Mohammed's data from Jordan. But we looked at our patients, and we had, these were not treatment recommendations that were prescribed by us. These were treatments that patients were adhering to when they came to see us at the NIH. And we had 45 patients at that time who were on no treatment. We had 10 patients who were taking vitamin C. There was a range of doses, anywhere from 250 milligrams to 4 grams per day. And then we had patients who were on a low protein diet. And I don't actually have the particulars on what their low protein diet was. This was just something that they came to us and said they adhered to a low protein diet. We didn't have a nutritionist sort of document what their diet was. But when we looked at the results, is this working? We essentially found no difference between the mean 24-hour urinary homogentic acid excretions. So this meant to us that in our experience, vitamin C and protein restriction probably were not going to be of a great benefit for our patients, and we wanted to think about some other alternatives. This is also consistent with the data that's been in the literature for many years. There's been no convincing studies that have shown that vitamin C and protein restriction were beneficial for the patients, and they're actually fairly difficult diets to adhere to for the long term, particularly if they're introduced in adulthood. So that leads us to nitisinone. This is the structure for nitisinone. It has a very long chemical name, so we affectionately referred to it as NTBC for a long time. It started to be used in 1992 for the treatment of hereditary tyrosinemia. And by the late 90s, we were starting to get word about the dramatic effects that it had for kids with hereditary tyrosinemia. It really revolutionized treatment for tyrosinemia type 1 and was a life-saving medicine for those children. When we looked at the pathway, we said, wow, I think patients with Alkaptonuria could really benefit from this medication too. So lucky for us, the medication was approved for the treatment of hereditary tyrosinemia type 1 in 2002. And that was timely for us because we were, at that point, pretty well entrenched in the natural history study, trying to learn as much as we could about Alkaptonuria. Now, you guys have seen this pathway a couple of times. Yesterday, just for a quick review, this is the tyrosine degradation pathway. The third enzyme in the tyrosine degradation pathway is the homogentisate 1,2 dioxygenase. This is the enzyme that's deficient in Alkaptonuria. And nitisinone's site of action is right here at 4-hydroxyphenylpyruvic acid dehydrogenase. So it's the immediate precursor for Alkaptonuria. And if you can prevent or block this enzyme, you can effectively eliminate the production of homogentic acid. So, as I mentioned, we were at that point in the midst of a natural history study trying to learn as much as possible. But when the drug was approved in 2002, that gave us a great opportunity to try some proof of principle studies. So we elected to give nitisinone to 2 patients with Alkaptonuria. These were intended to be very brief studies. The whole idea was to see if we give an individual nitisinone, can we reduce the homogentic acid that is excreted? So these are the 2 patients. This graph is for the first patient. So this was a 51-year-old female. And so along the x-axis, that's the number of days that she was followed. On the left side, we have urinary homogentic acid in grams per 24 hours. And on the right side, we have plasma tyrosine. So this individual, we didn't know where we were starting, so we just kind of picked a dose. And we started with 0.35 milligrams twice daily for 7 days. And then the plan was to increase her to 1.4 milligrams twice a day. And we actually had a pretty nice result. So the pink line is the urinary homogentic acid. The blue line is tyrosine. And when she was started on the 0.35 milligrams twice daily, we had a decrease in 24-hour urine homogentic acid from 2.9 grams per day to 0.9 grams per day. When her dose was increased to 1.4 milligrams twice daily, she had a further decline in her urinary HGA to 130 milligrams per day. So that was a pretty substantial decrease. Again, we were very new to this, so we were very conservative. We followed her plasma tyrosines, and she started off with a plasma tyrosine of 60 micromolar. By day 7, right in here, she was up, her tyrosine levels were 697 micromolar. And then by day 10, after the second increase, she was at 719 micromolar. Day 10 actually was the day that we got the results from the plasma tyrosine from day 7. And when we found her tyrosine levels at about 700, the medication was discontinued. We continued to watch her for a couple of weeks, and she had a very slow return to normal of her tyrosine and a slow rise in her homogentic acid back to baseline. So we took a second patient. This individual was going to stay on 0.35 milligrams for the duration of the study. She was on the medication for 9 days, and we saw a decrease in urine homogentic acid from 6.4 grams per day to 1.7 grams per day. And that was by day 9. She also had a significant increase in her plasma tyrosines. She started off at 67 micromolar, which is down here, and by day 7, her tyrosine had increased to, day 8, 1147 micromolar, and by day 9, she was at 1288 micromolar. And we got the day prior's results back, so the medication was discontinued at that time. We were a little anxious about a tyrosine of almost 1300. And her homogentic acid increased. You can see a little bit of variability here. And her tyrosine levels came back down towards normal over the next 25 days. We consider that a great success, though, because remember, our goal for this was just to prove that if you give a patient nitisinone, that you can reduce the urinary homogentic acid. So this led us to our second trial, which was really a pilot study. In this trial, we recruited 9 individuals. And the goal of this study was to try to determine what was going to be the best dose for us to use, and also to evaluate sort of the safety profile in our individuals. So because we were trying to determine the best dose, we did an incremental dosing regimen. We started off with 0.35 milligrams twice daily. The goal was to follow those patients for 7 days. At the end of 7 days, if their urine homogentic acid was less than 500 milligrams per day, we would maintain the patient at that dose, discharge them, and then they would be followed for the next 15 weeks. If urinary HGA was not less than 500, we would do a dose increase to 1.05 milligrams twice daily. Again, after 7 days, we would check urinary homogentic acid. If it was less than 500 milligrams per day, they would be discharged on that dose. And if not, we would increase the dose to 4 milligrams twice daily, again with the same idea in mind. Actually, all 9 patients, well, all of them required the initial dose increase. So none of them were less than 500 milligrams at day 7 on the initial dose, but all 9 of them were below 500 with the second dose. So we stopped all 9 patients at 1.05 milligrams twice daily, and we followed them for 15 weeks. This time we decided not to be quite as nervous about plasma tyrosine levels and decided we would just let plasma tyrosine go. We were not going to stop the medication for a particular rise. We wanted to see how high it would go, knowing that there was a risk for ocular symptoms, but we would follow the patients very closely. Finally, we wanted to see during the last week of the 15-week trial, if we put the patients on a protein-restricted diet, which was a 40 gram per day limit of protein, if we could reduce plasma tyrosine levels and urinary homogentic acid further while they were on their dose of nitisinone. So these are the average results for our patients. Again, oops, sorry. Along the x-axis, this is the day of treatment. Down here, this is when they were on the low-protein diet. This time we've switched it around on you, so plasma tyrosine in micromolar amounts is on the left side, and urinary homogentic acid in grams per day is on the right side. The blue line is urinary homogentic acid. The pink line is plasma tyrosine. So as a group, all 9 patients started off with a homogentic acid excretion of about 4 grams per day. On the 0.35 milligrams twice daily, they had an average homogentic acid of 1.4 grams per day. And then on the dose of 1.05 milligrams twice daily, they had a decline to 230 milligrams per day. So the patients were maintained on this and maintained levels around 200 milligrams for the duration of the study until they hit the low protein diet. So when their diet was restricted to 40 grams per day, they had a further drop to 130 milligrams per day. As expected, plasma tyrosine levels rose, and on the dose of 1.05 milligrams twice daily, they had an average plasma tyrosine of 760 micromolar. And when they were on the protein-restricted diet, plasma tyrosines decreased to 603 micromolar. So we did have a nice decrease on the protein-restricted diet, but that's still above, for kids who are being treated with nitisinone with hereditary tyrosinemia, the goal is to try to keep plasma tyrosines below 500. So while we were closer to that, we were still not sort of at that goal mark. But we were really pleased with this because this showed a 95% reduction in homogentic acid using 1 milligram twice daily of nitisinone. And this is just a little bit further information about the protein restriction that the patients underwent during the last week. This column here, so I'm going to get to this in a minute. We had 4 patients who had to drop out during the course of the study. So we had 5 patients who completed the entire 15 weeks. This was what their diet, when analyzed by a nutritionist, this was what their average intake of protein was. Average was about 57 grams of protein a day. And then when they were on the protein-restricted diet, you can see how well they restricted their diet during that last week of the study. These are plasma tyrosines while they were on their regular diet and the decrease that was observed on the protein-restricted diet. So again, regular diet about 57 grams a day. When they were restricted, an average of 33 grams per day. And we saw a decrease from 755 micromolar to 603 micromolar. So we experienced a few adverse events during the course of that short pilot trial. The first was one individual who, about a month into the study, had a renal stone that decided to pass. Unfortunately, it passed just far enough to get into the ureter and then get stuck. So that was not a lot of fun, and that patient actually required assistance having that stone removed. But that individual was allowed to stay on the medication for the duration of the study. That event, we didn't really know if that could possibly be related to nitisinone use or not. And the only way that we thought it could be related was that possibly on nitisinone there was maybe some dissolution of the stone, so it had been a larger stone, and with a little bit of loss it was then allowed to pass and get stuck, but that was really kind of a stretch. Otherwise, we couldn't think of any relationship between that and the nitisinone use. For patient number 3, this individual had a critical aortic stenosis that then became symptomatic near the end of the study. This was not felt to be related to nitisinone in any way. She had a critical aortic stenosis at the time she enrolled in the study. She was not symptomatic at the time of enrollment, and we don't know what it was that made her become symptomatic in the course of 2 months, although she was pretty heavily scrutinized and queried, and perhaps that just kind of brought it to the forefront that maybe she was indeed having some symptoms. Nonetheless, near the end of the study, she was taken off of the medication and transferred for an aortic valve replacement. And then we had 2 individuals, it was a little bit unexpected for us, who had elevations in liver transaminases, one on day 5 and one on day 32. The rise in the liver transaminases was really pretty mild, but again, we were looking for any possible side effects, and we had to be very conservative about stopping the medication. So once levels got between 70 and 100, these individuals were taken off of the nitisinone. It should be noted that both of these individuals had a history of heavy alcohol intake, and they were also both on many medications that are liver metabolized and had possible liver toxicity. So it's unclear to us whether that has any relationship to nitisinone use or not. Possibly nitisinone in synergy with some of these other medications, or history of substance abuse may make the liver a little bit more irritable, so we get a little bit of a rise, but these were pretty mild increases, so possibly related to nitisinone use. The big thing we were looking for were the corneal crystals that have had so much sort of publicity and things that have been reported from the hereditary tyrosinemia literature, and we did not see that in our 9 patients, so we were really pleased with that. The other thing that's been reported in children with hereditary tyrosinemia is a transient leukopenia or thrombocytopenia, and again, that was not something we experienced when we used the medication. So what did we learn from this pilot study? Well, we decided that the dose to try in adults was probably going to be optimal at about 2 milligrams per day. We were satisfied that this reduced urine homogeticic acid excretion by 95%. Plasma tyrosines did increase more than 10-fold, but systemic effects appeared to be pretty minimal, and we were really happy with that. Liver toxicity was something that was new for us, something that we felt like we needed to keep a close eye on, and we were also pleased that there was no corneal symptoms in those 9 patients. So that led us to the long-term study. In this study, we had 40 patients enrolled. 20 of the patients were randomized to receive nitisinone, and 20 of the patients were in the control group. These were all adults, and they were all symptomatic at the time they were enrolled in the study. It was a randomized single-blind study, so our outcome parameters were musculoskeletal markers, and our physiatrist who was measuring those musculoskeletal parameters, she was blind to the patient's randomization. The patients were not blind because when you're on nitisinone, your urine no longer turns dark, and so the patients can figure out very quickly what arm they're on. And the medication was very kindly supplied by Swedish Orphan. So this is the average for the 2 groups of the urinary homogeticic acid. Again, along the x-axis, this is month of the study. This is urinary homogeticic acid in grams per 24 hours. The red line is the group that was treated with nitisinone, and the blue line is the control group. And so on 2 milligrams a day, we did once a day dosing for this because of the long half-life. We decided it didn't need to be dosed twice daily, but once daily would be sufficient. Both groups actually started with a urinary homogeticic acid of about 5 grams. The group that was treated with the nitisinone had a very rapid decline. We didn't actually measure it again until their 4-month visit. And at 4 months, they had an average homogenesic acid of 125 milligrams per day. And the level was maintained pretty close to that for the duration of the study. It averaged anywhere from 113 to 203. Whereas the control group maintained a homogenesic acid between 5 and 6 grams per day throughout the duration of the study. Plasma homogenesic acid, this is a little bit trickier for us to measure. We don't have a lab in the United States that will measure plasma HGA, so we had to send our samples to Germany. When we started, we measured all of the patients with no treatment, so basically all control samples, and the average plasma concentration of homogenesic acid was 5.74 micrograms per ml. Homogenesic acid was then measured in our study patients on 3 separate occasions. Sorry to keep doing that. 34 of the 55 samples were below the lower level of quantitation, which is 0.25 micrograms per ml. So a normal individual is less than 0.25 micrograms per ml. And unfortunately, there's a pretty big range in there. So we can't tell you how far below the lower limit our patients who were treated were. I have no idea how close they were to the normal range. And so for calculation purposes, these 34 individuals were calculated with a level of 0.25. And when we did that average for the group on treatment, we had an average of 0.3 micrograms per ml. It may well be below that because, again, I don't know how far below 0.25 those individuals are. Anyway, we were very happy with this because this also showed that plasma homogenesic acid can be decreased by 95% using nitisinone. And finally, plasma tyrosine. This is not going to be a surprise to anybody, but similar to the pilot study, we had a fairly dramatic rise in plasma tyrosine. Again, along the x-axis, this is the month of study. This is plasma tyrosine in micromolar amounts. And the red line represents the treated group. The blue line is the untreated group. Both groups started with an average tyrosine of 60 micromolar. Patients treated with nitisinone had a rise on average to about 800. We had some individuals down around 500. We had some individuals as high as 1,500. And the individuals in the control group maintained right at about 60 to 80 micromolar for the duration of the study. In this study, we did have one individual out of 20 who developed the ocular symptoms that we were really looking for. Hopefully this projects, but this is sort of the classic finding that we see with the tyrosine crystals depositing in the subepithelial layer of the cornea. You can see this branching pattern. Hopefully that projects. I don't think it's projecting as well in this image. So this individual, within a month of starting nitisinone, started to complain of photophobia, some ocular pain. And when he was brought back to the NIH, and this finding was confirmed. We checked his plasma tyrosine levels, and his tyrosine was 615 micromolar on the first and 524 on the second checking. So he actually, obviously they're elevated, but certainly not as high as some of our other individuals who had no symptoms at all whatsoever. We put him on a protein-restricted diet of 40 grams per day, and there was no resolution of his corneal symptoms. So he was taken completely off of the medication. The good news is, within about 2 weeks, there was complete resolution. You could no longer see the deposits, and he had complete resolution of his pain and his symptomatology. We attempted to start him back on the medication, and we had sort of an alternate dosing regimen of 3 weeks on the medication, 1 week off. Unfortunately, we reintroduced it twice, and each time he developed the corneal crystals at an earlier point in the study. So we never actually made it to the 3 weeks before he got the 1 week holiday. So he was taken off of the medication for the duration of the study. Other adverse events, we did have one individual who developed atrial fibrillation 2 weeks after starting nitisinone. He was taken off of the medication, but unfortunately suffered a fatal myocardial infarction 4 weeks later. This was felt not to be related to nitisinone use. He had a very strong family history of heart disease, and he actually had pretty significant coronary artery involvement at the time he was enrolled in the study. But once again, we had another, this time a female, who developed elevations in liver transaminases while on the study. This didn't occur right away. She was about a year into the study when she was noted to have elevations. At that time, she had pretty severe right upper quadrant pain and was found to have gallstones. So they took her off the medication, took her to surgery, removed the gallbladder, and when her liver transaminases normalized, she was restarted on the medication on the alternate dosing regimen, so 3 weeks on, 1 week off. 8 months later, she came to us for just a routine follow-up visit, and at that time, she was on a lot of medications. She was on a lot of medications for pain control, and really not under good control, and medications were a little bit scattered. So when her liver enzymes were elevated on that admission, we thought maybe it was due to multiple medication interactions. So we stopped the nitisinone, tweaked her medications, got her back under good control, liver transaminases normalized. We put her back on the medication on the alternate dosing regimen, and when she came back 4 months later, she again had elevations in her liver enzymes. At that point, no etiology could be found, so she was taken off of the medication. We continued to follow her, and her liver transaminases actually kind of fluctuated all along. So it's hard to know whether there was any relationship to the nitisinone. But again, she was on so many medications, and it might be a situation when you have a patient that's on many medications with possible hepatotoxicity that nitisinone may just be one more irritant for the liver. So finally, getting away from the work that we've done, I just wanted to highlight a few things that has come up in the literature recently about hereditary tyrosinemia and treatment with nitisinone. And this is actually a publication that came out in 2008 from the French group. And they were, really the point of the article was talking about the benefits of nitisinone for their patients. But they did highlight, They did highlight one concern, which was a high rate of schooling difficulties in children with hereditary tyrosinemia treated with nitisinone. In fact, about a third of their patients had schooling difficulties, and major cognitive disturbances were found in 6 out of those 8 children. So why is this? Cognitive issues have not been previously reported in children with hereditary tyrosinemia. However, these children prior to nitisinone therapy were very, very sick. Many of them passed away very early in childhood. So cognitive issues were sort of not something that was really visible or a primary concern at that time. So maybe it just was undetected. The other potential is it due to the high tyrosine? There's other disorders in the tyrosine degradation pathway, particularly tyrosinemia type 2 and tyrosinemia type 3. And it's been established in tyrosinemia type 2 that there are neurocognitive impairments in these children. Tyrosinemia type 3 is a little bit more questionable because there's so few patients reported with the condition. But to investigate this further, this is information from Eva Thim and colleagues that came out in 2011. And they wanted to look further into the elevations in the plasma tyrosines. In particular, they wanted to know whether elevations in plasma tyrosine would correlate with elevations in tyrosine in the CSF. So they had 3 children that they did spinal taps on to collect spinal fluid. And indeed, they found that there's a nice linear correlation between plasma tyrosine and CSF tyrosine. Normal CSF concentration is anywhere from 5 to 14 micromolar, and in these patients it's anywhere from 140 to 160 micromolar. So again, it's about 10-fold increase in the CSF, similar to that's seen in the plasma. They looked a little bit further because there's one question that comes up. Tyrosine is a precursor for several neurotransmitters. One of them is dopamine. So if you are really sort of driving, can you drive the neurotransmitter pathway by sort of overwhelming the system with tyrosine? And so this same group looked at neurotransmitter metabolites in the CSF. Homovinylic acid is the breakdown product of dopamine, and the 5-HIAA is the metabolite of tryptophan. And what they found on this was actually pretty interesting. Dopamine metabolites were all normal, suggesting that just because patients have a high CSF tyrosine, that does not mean that they're going to have an alteration in dopamine levels. However, what they did observe was that there was low metabolites for serotonin, which was a little bit surprising. And all three of these patients had cognitive impairments or behavioral abnormalities. They went on to look at their cohort a little bit further to see the extent of neurocognitive impairments. And this is a really busy slide and too much detail to go into, but the take-home message is that they had 9 children. 2 of them were too young really to do full IQ assessments. So 7 really in this cohort with IQ assessments, and 5 of the 7 had low IQs. Motor abilities were impaired in 4 of the 7, and then language comprehension, production, and memory were only age appropriate in 1 individual. So this is a little bit concerning, and the questions now are circulating. Is it because of the high tyrosine? Can elevations in CSF tyrosine be neurotoxic? There have been studies looking at rats, and they've found a decreased antioxidant capacity in rats with elevations in tyrosine. In addition, there's been reports in the literature of pregnancy in an individual with tyrosinemia type 2 who was not under good control. She had high tyrosines during both pregnancies and had 2 children with cognitive impairments following that. So perhaps tyrosine itself has some toxicity. The other question that came up from these articles is, are there neurotransmitter effects? All the large neutral amino acids have a shared transporter across the blood-brain barrier. So if you overwhelm that system with tyrosine, there's going to be preferential transport of tyrosine into the CSF. In that last study, they had very low levels of tryptophan in the CSF. So perhaps high tyrosine is impairing tryptophan transport, and that may result in lower serotonin levels. The bottom line is we have no idea how that may have an impact on adults with alkaptonuria with high tyrosines. Is it possible that it could affect cognitive function, mood, memory, sleep? We just don't know. But I think it's something that we really need to be aware of as we're thinking about dosing and thinking about the plasma tyrosine levels in our patients. And perhaps you guys have some ideas about the high tyrosine, whether that has any impact on patients or not. Coming back to our study, we did have a couple of patients who reported difficulties during the study. It's hard to know for sure because when you're asking patients, repeatedly, any changes in your memory, sometimes they think, actually, yeah, I couldn't remember my grocery list when I went to the store the other day. So we did have a couple patients who reported that. One, we went far enough to do sort of standardized neurocognitive testing, and there was not an obvious memory deficit in that patient. The other 2 patients, we just did bedside testing, and again, their memory appeared to be normal. We also had a couple of patients who mentioned that their mood was potentially a little bit off. But again, it's very subjective. It's hard to know because the patients are being asked every 4 months about any of these changes. But I think it's something for us to think about. So in summary, our experience with nitisinone was very positive. It was very effective at lowering both urine and plasma homogenesic acid by 95%. Tyrosine levels increased tenfold. Overall, the medication was very well tolerated. The corneal toxicity was infrequent. There's the potential for hepatotoxicity, something I think that we still need to keep an eye on. And then I just want us to think about any sort of long-term cognitive consequences. And with that, I'll take any questions.